So if we start off with our ECG of the week, can anybody interpret this ECG for me? What does this ECG show? So what does this ECG show? Can anybody tell me anything about this ECG? So is this sinus rhythm or is it atrial fibrillation? Good, so we've had comments that it's sinus rhythm and it's a broad QRS. So is this just sinus rhythm with left bundle branch block? What about this ST depression that we can see in the lateral leads, infralateral leads? Is this anything to worry about? Is this just part of the left bundle branch block? What about the ST elevation that we see in V1, V2? Is this just left bundle branch block? Is it normal left bundle branch block? And what do you think about the PR interval? Has it got a normal PR interval? It's got quite a short PR interval, absolutely. So does that give you a hint? Have a look in V5, V6 at that P wave in the very short PR interval. Yeah, so this is a delta wave. This is a slurred upstroke of the QRS that suggests that there is an accessory pathway. And depending upon where that accessory pathway is, you can get very markedly different appearances of your ECGs, and you can localize where the pathway is on the basis of the ECG, which is very helpful if you want to do an ablation, because it means you can find the right bit of the heart to start searching for the very precise spot in, rather than just searching the entire heart. So this is Wolff Parkinson White, and this broad left bundle branch block is caused by conduction through the accessory pathway. T-wave, ST depression, T-wave inversion in left bundle branch block, the T-wave tends to go in the opposite direction to the QRS. So this is not ischemia with left bundle or with this ECG. That's just an example of another delta wave. This is a less extreme example. It's not obviously left bundle branch block, but here you've got fusion of conduction through an accessory pathway merging with conduction through the AV node. And again, you can work out where that accessory pathway might be. So what do we mean by an accessory pathway? We mean that the conduction, generally speaking, is going through the AV node, from sinus node through the atrium, through the AV node into the ventricle. But there is also an accessory pathway, because normally, as you recall, the ventricle's isolated from the atrium and can only get through the AV node. But when you have an extra electrical wire, that wire is called an accessory pathway. And so this signal, rather than being held up at the AV node, can conduct through the accessory pathway. And because then that doesn't plumb in to the normal electrical conduction system, so it doesn't rapidly conduct to the ventricle. Instead, it gradually goes through the ventricle, and that's why you get the slurred upstroke, and often it fuses with conduction through the AV node. Now, that accessory pathway can conduct forwards and it can conduct backwards, and that means that you can have a signal going down through the ventricle, going back up through the accessory pathway, and then forming a circle that goes round and round, and that causes a supraventricular tachycardia. Depending upon how slickly the accessory pathway can conduct, if you were to go into atrial fibrillation, that could expose the ventricle to very high atrial rates of atrial fibrillation, rates of around 300 to 500 of swirling electrical activity, which would put the ventricle into ventricular fibrillation. So AF is a concern in any patient with an accessory pathway, so we would always want to send them to EP for assessment. If that accessory pathway can't conduct quickly, then it's not a problem. But if it can conduct very fast, then that needs to be ablated for safety of the patient, because these patients with Wolff-Parkinson-White are at higher risk of atrial fibrillation than the background population. Great. So with that brief digression, let's move on to the main topic of today, which is ischemia. And this is very much intended to tell you about chest pain and about how, as a non-specialist, you should interpret chest pain and what you should do about it. In particular, I want to talk about the management of stable angina. But before we get as far as stable angina, we need to think about, is it angina or not? So we need to go through the differential diagnosis of chest pain. We need to go over what aspects, what characteristics of the pain make it cardiac. We'll talk about the differentiation between stable and unstable angina, go over a few ischemic ECGs, talk a bit about troponins and troponinitis. That's a made-up word for people seeing troponin and immediately saying it must be an stemi or ACS. And we'll then talk about the management of stable angina. So if we start off with the differential diagnosis of chest pain, can you throw me some suggestions of causes of chest pain? And even better, can you tell me, so pneumonia can cause chest pain, yeah? Pneumonia itself, does it cause chest pain? Pulmonary embolism has been suggested that absolutely causes chest pain. So a big group of the differential is going to be respiratory causes. So pneumonia, if it's causing pleurisy, would cause chest pain. And what's the characteristic of the pulmonary causes of chest pain? So classically, you would expect it to be pleuritic in nature, so related to inspiration. I've had a few other suggestions. So we're just sticking with pulmonary. We could also have pneumothorax, but musculoskeletal and costochondritis has been suggested. There's sometimes an element of pleuritic, worse on inspiration, but it's usually there's a focal area of chest pain. Now, if we think it might be costochondritis, we want to press over the area and see that it causes chest discomfort that is the same as the pain that they've come in with. If you press on the area and they say, ow, get off, and they're having a STEMI, they probably just don't like extra pressure on their chest when they've already got severe chest pain. You want to be clear that it's the same pain that's brought them in and that it's made it worse, and ideally that it's a focal point. So you can say there's a specific costochondral junction that's inflamed. Thank you. So another suggestion of esophagitis. So GI causes of chest pain, and so dyspepsia or GORD would be a common cause, and I've specifically given esophagitis. So what aspect of the pain makes you think it could be esophagitis? So heartburn, obviously, it's burning pain, thank you. So burning pain is helpful. Pain which is worse with particular meals and is affected by food. It can be made worse by eating or relieved by drinking milk or it can be worse if patients are lying flat, if their pyloric sphincter isn't working very well. So lots of things can affect it, but the esophagitis bit, what is esophageal spasm causing pain? Well, esophagitis, I suppose, I'm thinking of esophageal spasm, which is slightly more specific than that. And the thing about esophageal spasm is that it can mimic angina very closely. It can come on without warning, usually at rest. It wouldn't be made worse with exertion, but it's often a sharp central chest pain, doesn't radiate, but it's often relieved by GTN spray, and it can be in association with heartburn. So that's one to watch out for as a reason why GTN might relieve the pain. Good. So we've got through quite a lot of different causes. Can anybody suggest any other? Excellent. So pericarditis and aortic dissection. So the classic symptoms of pericarditis would be that the pain is affected by posture, and it tends to be worse lying flat, tends to be relieved by sitting forwards, and it's worse on inspiration very often. It's long-lasting pain that tends to come on relatively gradually, and it might be present for over 24 hours. May be associated with a rub, although that's relatively uncommon. Aortic dissection, on the other hand, how do you differentiate aortic dissection? Let's put up my list of differentials because I think we've got pretty thoroughly through them. So the pain of aortic dissection classically comes on very suddenly. It's a tearing pain and it radiates through to the back. And aortic dissection can be associated with occlusion of the coronary arteries if the dissection flap occludes the coronary arteries. So you can have a STEMI on top of your aortic dissection. We haven't talked about herpes zoster. We could also say that valves or tachyarrhythmias, those can make stable angina unstable if they get worse or a tachyarrhythmia occurs. And there are lots of other non-physical causes of chest pain, and chest pain is one of the commonest presenting features to GP surgeries. Obviously, most chest pain isn't cardiac, but it's a very challenging diagnosis sometimes to exclude, and obviously a high risk one. We have got some quite a nice paper from JAMA from 2005, which looks at the different types of symptom that you get with chest pain, and I think this is well worth reading. But if I just show you the sort of top line, this sort of history that you learn in the textbooks is based on something. There are research studies which are quite old now because people don't keep on reinventing the wheel, but they find that chest pain that obviously radiates, that is associated with exertion, and is associated with sweating, nausea, and vomiting, those are pretty good at increasing the likelihood of this chest pain turning out to be ischemic. Now, of course, the likelihood ratio is going to be very much affected by the population of people that you're asking, but it gives you a sort of a ballpark figure, bearing in mind that these are different references. So this is a very imperfect work of research, but it's informative. Radiation to the right arm or shoulder, curiously, is actually more helpful than if it radiates to the left arm or both arms and shoulders. But I think the take-home point there is that because it's much less likely to be common, doesn't matter if it radiates to the right or the left arm, the fact it's radiating to an arm or shoulder is a concern. If it's worse than previous angina or similar to previous MI, I don't tend to so much ask, is it worse? But similar to previous MI is very helpful. And if it's similar to a previous MI, the fact then that it's worse would point towards a potentially an acute coronary syndrome. And the description as a pressure or crushing pain is helpful. So these are all factors, although can you see that's only 1.3, so much less helpful than the radiation. So those are all very useful, and things I would say I find most useful are the association with diaphoresis, nausea, and vomiting. It's unlikely that it's ischemic if you don't have some of these factors. or it's unlikely that they're having an end STEMI. It's possible to have an episode of angina without all of this. On the other hand, factors that decrease the likelihood. So if it's pleuritic, your chance is down at 0.2. So it's a very, very good rule out of cardiac pain if it's, or of ischemic cardiac pain if the pain is pleuritic. And then positional and sharp are also good rule outs, although bear in mind that often patients will describe sharp pain as severe pain. So if you ask us it's sharp and they say yes, oh it's really, really sharp, then ask them, is it feeling like being stabbed? Is it that kind of sharp and very severe, or do you just mean very severe by that? And very often they will agree that they just mean very severe by that. One thing to watch out for is I've had patients who are in severe distress, who are, really in severe discomfort. Um, and if you ask them in their pain, are they in pain, they will say no, but they will say they've got a terrible tightness in their chest. They just don't think of tightness as being a pain. So just be a little bit careful that ask about tightness and pressure, and consider that patients sometimes don't see that as being painful. We talked already about palpation, if it might be costochondritis. If it's on the left side rather than being central, that makes it less likely, but not hugely less likely. And the association with exertion is also not so helpful, but maybe of some use. Bear in mind that if your patient if they're a Caucasian male, they do tend to have read the textbooks and to present as this would suggest. But patients who don't have English as a first language may have cultural differences in the way they think about pain, and that may affect the way they describe it, particularly in women. So just have a real careful think before you rule out ischemic heart disease, particularly if you're having trouble with the history, or having trouble communicating with the patient. Good. So coming back to chest pain, we can separate out cardiac causes of chest pain into stable angina and into unstable angina. So can anybody tell me what makes angina stable? So we've had a suggestion come through. It's exertional, absolutely. So exertional is one of the biggest factors. And what's the other big factor that you're looking for? Two other big things that I'm after. So only exertional. Uh, Relieved by rest, maybe, but that's so it's got to have a duration less than 15 minutes, and it's got to be stable. It's in the name. So exertional, relieved within 15 minutes of rest, and it's got to have been present unchanging, so reproducibly. If the person goes up a particular hill that they regularly walk up, they get the pain at the same time. Now it might be affected by it being cold or windy, or them having had a big meal, but by and large it's stable, it's chronic. Unstable, on the other hand, that fills the opposite of that, new onset. So even if you have angina on exertion, the fact that it's new onset makes it unstable, because you must have had a new change in your coronary arteries, that now all of a sudden you're getting chest pain doing exercise, even if it only comes on with relatively vigorous exercise. And if you've got a new ruptured plaque that's caused a new stenosis, even if that's not that's only causing exertional chest pain, that new area hasn't healed up and become stable, and so you are at higher risk of that turning into an infarct. So any new onset angina is by definition unstable. And if the patient is, either you're seeing them elsewhere or in general practice, if they are currently in pain, or if the pain is in the last 12 hours and their ECG is abnormal, they need to be sent in as an emergency, because you can't tell. You can be confident, but you can't be certain from a history, and it's really hard if you're a non-specialist. But if they're currently in pain, you can't be sure if that's ischemic or not without doing things like a troponin. And you shouldn't be doing troponin outside of hospital, because if it's positive, you should have sent them into hospital. So it should just, these patients should be seen if you think it could be ischemic. So currently in pain, or pain in the last 12 hours and an abnormal ECG would buy you an immediate referral to hospital. If not, if it's unstable angina because it's new onset, but it's not happened in the last 12 hours, and the ECG is okay, they can be sent along to rapid access chest pain clinic, and they'll be seen within a couple of weeks in that clinic. And the vast majority of patients that they see don't turn out to have ischemic heart disease. But about 50% need further investigations, about 2% need admission, and those are the ones that perhaps shouldn't have been sent to rapid access in the first place. They perhaps should have been admitted, although clearly it's there to fish those out, because there's always an element of uncertainty there until you've got the answer. So that's the difference between stable angina and unstable angina. And the big question you might ask is, so when is angina stable? How long do you have to have had it for before your unstable angina actually you can start to call it stable? And I can't give you a definite answer to that. I would say I'd probably have in mind a figure of about a month, but certainly after a few months, I'd be calling it stable angina. So let's have a quick look through some ECGs. Does anybody want to interpret that ECG for me? Great, so it's an inferior MI. So why do you think that's an inferior MI? So you're looking at the ST elevation in leads 2, 3, and AVF. Now I'm being told it's an inferior posterior stemi. So here we can see that there's ST depression in V2, and there's a little bit in V1 and quite a bit in V3. Now it's hard to know if this is reciprocal change or a posterior stemi, but given the extent of the ST depression here, which is as great as the ST elevation, I would be thinking of posterior stemi. Infraposterior stemi has just been suggested, and I would be thinking of doing a right-sided leads and posterior leads to try and help clarify that. But I'd only be doing that for entertainment while waiting for the patient to go straight to the cath lab, because this sort of patient needs to have an immediate coronary angiogram, because they've got inferior ST elevation and there's lots of R wave here, so you know they've not fully infarcted, and there is ST depression elsewhere in the ECG, which could represent a posterior STEMI, but reflects the fact that this is acute ischemia as opposed to something like pericarditis, which can cause saddle-shaped ST elevation and can rarely be focal. What about this ECG? So I've got a patient at the moment who's had some anterior T wave inversion and a negative troponin, and we talked about how her ECGs didn't particularly look ischemic. This, on the other hand, can you see these arrowhead deep T wave inversions? This would be a classic LAD syndrome ECG, and the concern here is that this must be a proximal LAD lesion to be causing T-wave inversion in so many leads. And therefore, if that occludes, it will be a really big infarct. So if you see an ECG like this is an emergency hospital admission ECG, because the risk of the patient having a big infarct or dying is high. so they need to be straight into hospital. You would expect a positive troponin with this. It would be very odd for the T-wave inversion to be caused, but you not to have a positive troponin. In fact, so odd, I would draw the diagnosis into question, because often this is a patient who will have had severe ischemia briefly. You can see they've not lost the R waves. But the arteries reperfuse soon enough that they haven't done any real damage. And often the ECG, when you see them, doesn't show much by way of ischemia, but then the next day the ECG looks like this, and you realize that that person is high risk and needs an urgent coronary angiogram. Very good, Ward 28. So moving on, what about this ECG? Okay, so I'm being told this is an anterior stemi. We're also being asked, is it query LV thrombus? So both good suggestions. Can anybody, they're not quite what I'm after. Can anybody think what I'm after with this ECG? So there is ST elevation in V1, 2, 3. Thank you. So, but as you've just now all suggesting, there are Q waves. So remember, the Q is the first negative deflection of the QRS, providing it comes before an S wave. Because if you've got an S wave, as you have here, an R wave, as you've got here, that is followed by an S wave. So there is no Q wave here because it goes up first as an R and then down as an S. Whereas here, there is no R wave, it just goes straight into your S wave, so straight into your Q wave. Dear, I need to hope I'm not muddling you. So we have Q waves because we've got a negative deflection before an R wave, and they've got that in V1, V2, and we've lost a lot of our R wave. Normally the R wave would be much bigger in V3. That, together with persisting ST elevation, would suggest an LV aneurysm, and an LV aneurysm might mean that you have a thrombus in your heart because of the non-moving wall that's dilated, the sluggish blood flow in that area, so clot forms. So this is probably a old anterior STEMI. It could be a late presentation anterior STEMI, you don't know. So find out when the pain happened. If this patient had severe dyspepsia a week ago that they just took some Gaviscon and went to bed with, then that could have been a big infarct happening a week ago. Or this could have happened 10 years ago. You can't tell how old it is from the ECG. So if the patients you're seeing with chest pain and you see this ECG, that's something where you think, is the pain within the last 12 hours? Is the pain ongoing now? And that's the kind of ECG that if they're in pain, you don't think it's an acute episode related to that pain necessarily, but they need immediate assessment. If they're pain-free, maybe. If the pain was a few days ago, you could think either, if you're convinced that this is long-standing, the patient might have a history of an old myocardial infarction, you might want them to go to rapid access chest pain clinic, but have a low threshold for admitting somebody like this because of the risk that they're having further ischemia, which they're unlikely to tolerate very well. And then finally, this ECG is the last one I want to show in the context of chest pain. Can anybody tell me what's abnormal about this ECG? Come on, everyone, this is really obvious, isn't it? So, good. Very brave. So it looks normal. And how much of the time is the ECG normal when patients have positive troponins? So what proportion of the time does the patient turn out to have had an acute coronary syndrome or an NSTEMI with a positive troponin, and yet their ECG was normal? So quite often, yes. So 50-50. It depends hugely on the population that you assess, but it's very common to have a normal ECG and yet turn out to have an NSTEMI. And obviously, we want to look at serial ECGs and always look at all the ECGs, always look at the ambulance crew ECG because STEMI can be very transient. You can have marked ST elevation that clears up 10 minutes later. But normal ECG does not rule out ischemia. It's just a very important part of assessing and working up patients with ischemia. We use troponins to rule out ischemic heart disease or rule out acute coronary syndrome. Troponins have come on enormously in the last 15 years. We used to use CKs. And as they've got better and better and more sensitive and more rapid, we have steadily got rid of diagnosis of unstable angina because most unstable angina, by definition, you've got an unstable new chest pains. That's just an unstable plaque, and that is likely to cause some damage as it ruptures and blood clots go down and block more distal vessels. So you expect some sort of troponin release with unstable angina, and that's why it's such a good rule out, even if you've only had a brief episode of pain. And that means that we send patients home telling them that they've had a heart attack, an NSTEMI. That really means something to a patient. But if their troponin was only 50, was that really an infarct? You don't want them to wrap themselves up in cotton wool. So I'm slightly frustrated with the definitions that we have, but they've got very, very good rule out. The negative predictive value of a negative troponin is very, very good for acute new onset unstable angina. Obviously, if it's a patient presenting with chest pain and they've stopped their medications, they've stopped their isosorbide recently, and that's why they're getting chest pain, you'd expect it to be negative. We don't absolutely rule out ischemic heart disease. We don't absolutely rule out acute coronary syndrome. And bear in mind that even if you rule out somebody's as having cardiac chest pain then and there, these patients are often high risk and might have an episode in the next week post-discharge. Obviously, the chances of that are hopefully relatively low for them and for you. But if that happens, it doesn't matter how good your test is. If they've got a new diagnosis soon after going home, your troponin's not going to help you with it. So it's a very good rule out, but it isn't 100%. And its sensitivity for acute coronary syndrome is not 100%. But it's about as good as tests will ever get. Bear in mind that troponins can go up with all sorts of other non-cardiac conditions. So fast arrhythmias, atrial-based or ventricular-based, will cause troponin release. And that could be demand ischemia. So if your patient has got coronary artery disease and stable angina, which they might not experience because they might not do any exercise, or most patients with coronary artery stenoses don't have symptoms with them. So when you make their heart go fast for a long period of time in fast atrial fibrillation, for example, that puts strain on the heart and the blood supply to the heart and causes a troponin release. You also get it with patients with left ventricular hypertrophy. So they're patients with hypertrophic cardiomyopathy or severe hypertensive heart disease that walk around with troponins of about 600 to 1,000 all the time. And that's because the cardiac blood supply is on the outside of the heart. So as you have thicker muscle, the blood has to perfuse further through the heart. If the pressure, the contraction is, the diastolic pressure in the heart is high, which you often get with hypertension, that means that the pressure that you're trying to perfuse against is higher. So it's harder to perfuse that muscle, which is thicker in the first place. And that means that you will tend to not perfuse it as well, which will in turn lead to increased stiffening of the heart muscle, because ischemic heart muscle becomes stiffer. And you can see how you get your troponin release and your chest pains from your hypertrophic cardiomyopathy or left ventricular hypertrophy. Things like anemia, obviously, if you're very anemic, you're going to be perfusing your heart less well, and your heart's going to have to work harder in order to pump more blood to get the same amount of oxygen to tissues. Hypotension will reduce the pressure of going down the coronary arteries. And obviously, hypovolemia links into things like hypotension. You can have the direct myocardial damage. So if you are in a car accident and you hit the steering wheel hard and often fracture your sternum, then you can have a cardiac contusion with that. And you can get all sorts of direct damage to the heart because of that, or aortic dissection because of things like that. Cardioversion, we wouldn't typically do a troponin after giving the heart a jolt with a cardioversion, but troponin is so sensitive that just a tiniest whisper of damage to the heart, it will pick up. So you can have that making a troponin increase. The infiltrative disorders, things like AL amyloidosis, as you stuff the heart muscle tissues full of the amyloid protein, some troponin leaks out. Chemotherapy can be cardiac toxic. It can cause myocyte apoptosis, so make the cells die, and as they die, they leak troponin. Myocarditis is a funny one. If you see somebody with fulminant myocarditis, they'll be incredibly sick and very severe LV impairment, and their troponin often will be up, but it tends to be in the thousands rather than in the tens of thousands, and it really doesn't reflect how poorly the heart is. It can be very high, of course, but myocarditis and monitoring the troponin to see if that's improving can be helpful. Good. And then anything that puts strain on the heart will cause your troponin to go up. So that would be things like heart failure or PE, but it would also be sepsis or any stressful systemic, any stress to the body will cause these problems. And that can put troponin up into the thousands. And we would call this a type 2 myocardial infarction. In fact, most of these that we've discussed would be in the type 2 myocardial infarction. That's where the chest pain is being caused by strain on the heart rather than by a coronary artery pathology, rather than by new plaque rupture and occlusion of a coronary artery with a blood clot. That would be a type 1 myocardial infarction. And type 2 myocardial infarction, the management of that is to treat the underlying cause. So it's not to do a coronary angiogram. It's not necessarily to put them on antiplatelets, but these patients would likely have underlying coronary artery disease, and so it becomes important to give them potentially, depending on how sick they are, secondary prevention treatments, and to think about if they should be seeing a cardiologist once they've recovered, because maybe they've got severe 3-vessel disease that's not known about, in which case maybe we should think about doing something for it. I say maybe for reasons that I will come on to shortly. So we've mentioned stable angina and the fact that this is patients who have chronic exertional chest pain which lasts less than 15 minutes. So if you're seeing a patient, you've taken the history, you've satisfied yourself it sounds cardiac, you've satisfied yourself this is a long-standing condition, so you've got somebody with stable angina in front of you, what do you do with them, bearing in mind that you can't phone a friend because your cardiologist is not your friend when you're looking after somebody with stable angina? So how do we go about looking after these patients? So the patient's getting impatient. Your silence and uncertainty is not filling them with confidence. What are you going to do? This patient can, walk a mile on the flat, but the moment they start going up a hill or a flight of stairs, or they rush, or it's windy, they start getting central chest tightness, which settles rapidly when they rest. What are you going to do to them? This has been happening the last 6 months or so. So you want an ECG? Yeah, you can do an ECG. Yeah, their ECG looks normal. What are you going to do next? Great. So we will optimize medical management for angina. So we want to optimize the medical treatment. What about sending them to the rapid access chest pain clinic? Don't you want to send them to the rapid access chest pain clinic? It's really stressful seeing this patient with this chronic episode of chest pain. Get somebody else to have a headache about it. Do we need to do that? No, we don't, thank you. It's rapid access is for patients who have unstable angina or new onset of chest pain and angina. Do you check the troponin? If you want to check a troponin, you've got to admit the patient to hospital, because if you check the troponin in general practice or in an outpatient setting and that troponin is positive, then why on earth did you send somebody with an NSTEMI home? That's dangerous behavior. So troponin should never be done for rule out of ischemic heart disease in outpatients. The only reason I'd do it is if I had somebody with amyloidosis and I wanted to assess their prognosis and the severity of their cardiac amyloidosis. I might do a troponin. So very, very small print reasons you just wouldn't have to worry about. So you might think about checking their bloods and considering things like thyroid function and cholesterol. But the thing you want to do is to optimize their medical management. Do anybody know the data for intervening, for trying to fix stable coronary artery disease, trying to make it better? Is it prognostically beneficial to do that? So are we going to make this patient with angina going up a light incline, are we going to make them better by unblocking that artery and making the arteries look pristine and new with a stent? So the trial I want you to tell me about is very easy to remember because it's called the Ischemia study. And this study looked at nearly 5,200 patients, the vast majority of whom had multivessel disease. So all these patients in this study had coronary artery disease, unquestionably narrowings of their arteries sufficiently severe that they could have an unblocking procedure done on them. And the vast majority of them had narrowings of more than one blood vessel. So they might have had a narrowing in their anterior descending artery and in their circumflex artery or in their right coronary artery, or even all three. So these are patients with very significant coronary artery disease. And all of these patients received good secondary prevention treatments. So these patients all need aspirin, they all need statin, they all need blood pressure control, they all need lifestyle stuff doing. All of that's very important. But important thing to say is these patients didn't have left main stem disease. So that's always when you have a patient with new onset stable angina, if they had left main stem disease, everybody agrees, me included, that they ought to be considered for intervention, and really that means surgery with the cabbage. But if these patients don't have left main stem disease, but they have severe narrowings elsewhere, they were managed in this ischemia study conservatively or with intervention. And this study cost $100 million to conduct, so really expensive but very important research. And this is a study that follows on from, there's a trial called Courage, which did a similar sort of a thing about 15 years ago. And then Barry 2D is another similar sort of study. So this isn't new, or it isn't isolated information, but this is an up-to-date confirmation with sort of latest management, because of course treatments move on. And it was published in the New England Journal, and it showed that if you had a conservative versus an invasive strategy, there was no difference in the primary composite endpoint. And if you break that down, there was no difference whatsoever in risk of death, but there was a slight difference in risk of myocardial infarction, not reaching significance. So we're just looking at a trend here rather than a real difference. And what you can see, that appearance is reflected in the primary composite endpoint over here. You're more at risk of an infarct early if you have somebody mess around with your coronary arteries. But in the longer run, you're at slightly more risk if you've had a conservative strategy not reaching significance by 5 years after presentation. So this is very good evidence that we don't benefit patients by intervening on them. If I was told that I was going to be more at risk in the first year versus later on, I would not be keen on rushing for that procedure. And this is a non-significant finding. Now, maybe another 5 years of follow-up might show that it benefits you in the longer term, but I would be surprised. I don't think these lines are going to separate further. So there is no reason from a prognostic point of view to unblock stable coronary artery disease. However, it is helpful for symptoms. So if you can't control a patient's symptoms, it's important that we consider offering them a STEMI, because if you've got a fit and healthy patient, you don't want to subject them to the rest of their life unable to walk up a hill without getting chest pain. They'll become overweight and unhealthy from lack of exercise. So there are good reasons to do this, but do it for symptoms rather than prognosis. And that means that if you're not working in cardiology and you've got somebody with stable angina, you can have the confidence that what you're doing is not affecting their life expectancy. It's helping with their symptoms. So you can be confident in treating these patients. Now, just bear in mind that that's completely different to treating a STEMI, where you can see an enormous benefit to doing an emergency STEMI primary PCI compared with here thrombolysis, which itself is about 27% better than doing nothing. So it's enormously beneficial to do a primary PCI and to unblock arteries that are acutely blocked. And it's of a significant benefit in an end-STEMI situation. It's in stable angina where it's a symptomatic treatment. So what is that treatment? We should separate it out into the prognostic treatments, which the patient should carry on regardless, and symptomatic treatments, which are obviously very important to make the patients feel better, but the prognostic ones are the ones they have to carry on anyway. The symptomatic ones are the ones that you can stop if they're not making the patient feel better. So our prognostic treatments, as we've said, are statins and our aspirin. So if you can get them on atorvastatin 80 milligrams once daily, I probably actually would go 40 milligrams once daily in somebody who's got stable angina, and that would be irrespective of their cholesterol. If their cholesterol is very high, maybe they need more. Maybe they need to see a lipid specialist, and I'd certainly check their cholesterol. But even if their cholesterol were very low, even if it was 3 or even 2.5, I would still want to put them on 40 of atorvastatin or another statin, such as rosuvastatin. But atorvastatin, I would say, is first choice. So very, very important that you give them a good dose, because while a low cholesterol reduces your risk of running into problems in the first place, if you run into problems, your risk reduction is as good if your cholesterol's low and gets even lower as it would be if it was high and got a bit lower. Aspirin, lots of uncertainty in primary prevention, lots of big trials which seem to show it doesn't really help, so we don't use it in primary prevention so much, but in secondary prevention, unquestionably we use it. And if they've got coronary artery disease causing stable angina, I'd consider them to be secondary prevention, and that's what the Ischemia trial did. Blood pressure control, if their blood pressure is very good, there isn't necessarily an argument for an ACE inhibitor, but beta blockers for treatment of symptoms or for their blood pressure. And then the lifestyle advice, the stopping smoking, the having a healthy weight, not drinking too much alcohol, and control of their diabetes. Can you reduce risk of acute coronary syndromes by good control of diabetes? The bottom line is no, you can't really. Diabetes, it's the microvascular complications that tight controls seems to be best for. If you overly tightly control diabetes, you can actually increase risk of mortality. But there are some very good newer diabetes medications for reducing cardiac risk. So here is where the SGLT2 inhibitors come in as being very good medications for diabetics with angina. And then healthy diet and regular exercise. So beneficial for patients to do regular exercise. We don't want them to try to exercise through the pain, but we don't want them to be not exercising for fear of bringing the pain on. A useful trial to have in the back of your mind when you talk to patients is the Samson trial. This falls into the category of trial I wish I'd been clever enough to do when I was doing my research, because this is just 60 patients and yet it's got into the New England Journal. And these 60 patients were given atorvastatin 20 milligrams for 4 months, a placebo for 4 months, and then they had no tablets for 4 months. If you then ask them their symptoms throughout that time, and obviously filled out while they were in these different 4-month periods, they had relatively few symptoms while they were not on any medications, although they weren't free of symptoms. But if they had placebo or a statin, they got basically the same amount of symptoms, and these symptoms were things like muscle pain. They then told the patients who couldn't tolerate either a placebo or a statin that they were actually on a placebo at the time, and that they were getting the side effects because of the nocebo effect, the fact they expected statins to cause harm, as statins have got a bad name quite often in the press. And 50% of those who couldn't take it before successfully restarted it again. So the expectation that you are going to get pain is causing the vast majority of the symptoms in the placebo and statin arms. And use that next time you see somebody who has some musculoskeletal chest pain with a statin as a way of trying to persuade them to give it a go again and have an open mind. I've had variable success with that, to be honest, but it is a useful and a really important finding that most of the side effects of statins are patients' belief that they're going to get side effects from statins. And then symptomatic treatment of angina. This is quite a useful stepwise strategy from the ESC guidelines. So it looks a bit more complicated than it really is. It's actually not that hard. Start off with, first step, somebody with angina, you want to try and make it better. A beta blocker or a calcium channel blocker are the best first treatments. If that doesn't work, you can either add a beta blocker. If you're using a calcium channel blocker, you don't really want to add something like diltiazem to a beta blocker because of risk of bradyarrhythmias, whereas a dihydropyridine calcium channel blocker like amlodipine or felodipine you can add, and it will work as an anti-anginal and it won't cause excess bradycardia. So amlodipine and beta blocker would be a second line, for example, if you started off with amlodipine or a beta blocker. And then if that's still not working, we need to think about one of the other drugs, which we'll come to in a second. If they've got a fast heart rate, that's where adding your diltiazem into your bisoprolol or atenolol becomes helpful. I wouldn't be thinking verapamil here. We certainly wouldn't add verapamil to a beta blocker, because that can cause heart failure and is really very profoundly negatively inotropic. So here it's diltiazem plus a beta blocker. If that's still not working when you've got both of those on, then you could think about adding ivabradine, which slows the heart down further, providing they're in sinus rhythm. It doesn't work at all in atrial fibrillation because that works on your sinus node. If they've got a slow heart rate, then your first line is amlodipine or felodipine, followed by a long-acting nitrate, so isosorbide mononitrate. And that would come in here if you've on the standard therapy arm. If you've got LV impairment, we do not want to give calcium channel blockers. So we would certainly want to go with a beta blocker. And then we could think about adding the isosorbide or ivabradine. And if we've got low blood pressure, that we might try low dose of our beta blocker or calcium channel blocker. We might try low dose long-acting nitrate, but just bear in mind the patient's risk of falling over and hurting themselves. We would be wanting fairly rapidly, unless those are well tolerated, to think about going for something which doesn't drop your blood pressure. And that's things like ivabradine, ranolazine, depending upon the heart rate, or trimetazidine. And then as a fourth step for any of these, we could think about those same drugs. Nicorandil, I'm not a huge fan of. I find that it causes quite a lot of side effects with ulcers, and it doesn't seem to work particularly well. Ranolazine I do find to be very useful. So if I've got somebody with low blood pressure, that's probably my go-to drug. But these are all options, and it's finding something the patient tolerates well, and you be confident in switching between them on the basis of things like watching their heart rate and their blood pressure, and maybe a combination is needed. So if your patient with stable angina is free of symptoms, having dealt with this, or is very satisfied by their symptoms, they don't necessarily need anything else doing to them. But if they have ongoing symptoms, then we would certainly want to become involved. So in summary, just make sure you know the difference between stable and unstable angina, and remember that troponin is a good rule out test, but it's not a very good rule in. There are lots of type 2 myocardial infarctions and other causes of troponin release. ECG is normal in 50% of acute coronary syndrome, so don't let that rule out acute coronary syndrome in your mind. That's only helpful really if it's positive. And stable angina, get the prognostic things in. And if you're not sure what you're doing, rapid access chest pain clinic is a really excellent way of getting your patients seen, but they're not really there for your stable, long-standing anginas. They're there for unstable chest pain. Thank you very much for listening. Have you got any questions?